you very much for the kind words of introduction. Actually, my presentation is aimed at learning. Because unless one thing I achieved in my career, I look back, basically I am an adult dermatologist. I have a MD in medicine. It was a scary task for me to come to LRH. My little bit of pediatrics exposure is during my internship with Prof. Senevirathne, who pioneered the pediatric surgery in the country in the 1990s, early 90s. So he used to operate on this TOF, incorporate anus, neonates, malrotation of the intestine. And at that time there was only a consultant and 2 interns. So we had to look after the babies. He operates, the babies are dumped in the ward, there are no pediatric ICU, and we used to look after them. 2 issues come to my mind apart from the fluid balance. Problems of temperature control. Those days, neonates, either hypothermia or hypothermia. We had to manage that, and there were no cannulas. There was something called butterfly. You can't do butterfly. You can't. 1 hour later it's out. We have to put another one. So then this post was created, and 2 of my good teachers, I think I have photographs of them. I am working currently on nature photography. Has been a hobby for the past 40 years or so. These are LRH look like when I first came. I think there's a new building here. That's a new building across this place. This was taken the day I came to LRH. So this is what I am going to tell you a case series about patient days. This is something I have created to tell you about, to learn from each patient, whether it's dermatology, OPD, pediatric, psychiatry, whatever the specialty. Because you may encounter part of what you see today, not the exact entity. In medicine, we don't see the exact entity in the second patient. That's a very rare entity. There will be slight variations in the history, examination and the findings. Even the diagnosis, if we make one pigmented tumor in one patient, you see another patient completely different. So this is what I am going to focus. So when my teachers, like Dr. Ridgeway and like Dr. Prof asked me, you can come to LRH, because no other dermatologist was willing to come here. I said, I'll come. Our time we sort of respected our teachers a lot. It's there still, I'm not saying it's not there. So when I build it up, scratch by scratch, I walk into an empty room. I remember with gratitude Dr. Jayamini, the director, the woman service for this place. And it was an era of clinical medicine. Now, from modern medicine, gradually we shift away from more towards investigation-based medicine. That's okay. But in the situation of power failures, corona, financial issues, computer failures, investigations may not be freely available. Say, yesterday I saw a patient with atopic dermatitis, and the person has gone to an immunologist who had done a series of investigations, 41,000. And the parent produced the list of sensitivities to almost all the household things. House dust mite, cockroach, gecko, birds. Now the parent is asking me, then, sir, what is the කරන්න කියලා. So I said ඉතින් මිදුලට වෙලා ඉන්න දැන් ඊයස්සේ ඉන්න දැන් මේ කියන ඔක්කොම ඇලර්ජි. Now that's the end point, you know. Allergy, cutaneous allergy occur because there's a defect in the skin. Because of the environment. When there's a defect in the barrier, allergens enter to the dermis. And you get antibodies to that. So this is an example of. So to my gurus, you know, like Professor Dharma said, mask clinician. When we were interns, I remember, he used to look at the breathing of the patient and say, there's left out pneumonia. By looking at it without examining the chest movements. They were master clinicians. I am so grateful for him. Because I was his intern, I was his registrar, last registrar, and master clinicians there. Dr. W.H. Pereira, who by the way had 100 marks for zoology, 1960. It was a record for so many years. His illustrations are better than what you find in books. Zoology. So it was a pleasure to be guided by them. And with Dr. Ridgeway, who was my teacher during senior registrar time, and Professor William Cunliffe, my teacher abroad. He's actually BSc and then PhD in acne and MRs. Now we learn from different sources as medical students, as medical officers, even consultants must learn every day. My God, never hesitate to learn. And these are the sources of learning in our time. But increasingly, internet has become the source of learning. But I think if you focus as members of the medical profession, we must not lose the focus on the subject. Stay focused. I have to stay focused on dermatology for my career, 32 years as a consultant. That helped me a lot to learn every day. We learn from colleagues, we learn from patients, so my focus is on the latter one. Now, Socrates once said, you can't teach anything to anyone, but you can make them think. In order to do that, Socrates introduced a type of medical teaching called Socrates method of teaching. That is, he poses a question on the student. So then the student has to think. So that's known as Socrates method of teaching medicine. Some countries, in certain old units in US, they still practice this. You have to stay committed. If you come across something that you don't know when you read or when you hear, go and clarify. Same when you take a history or an examination, you find something doesn't fit into the picture. You have to go back and see whether you have made a mistake. If you make a mistake in clinical practice, it's trouble. You see the publicity that we get in the media. Now, person who commented best about misdiagnosis is Anton Chekhov, the world famous Russian author. He gave up medicine to become a novelist. He once said, medicine is my wife, literature is my mistress. Is the Chekhov's word of it. Unfortunately, since he is Russian, his monograph on misdiagnosis was never published in the Western literature. But I think New England Journal of Medicine once published about the problem of misdiagnosis. Now, when I have included some adults also because we pediatric dermatology work, we were taught that this is, speckled leukoderma is very characteristic of systemic sclerosis. No, it's not so. This occurs as a result of deposition of amyloid in the skin. So, people who use a scrub, especially village people, use a stone to rub thinking that there's, dirt and stuff, results in dermal damage and deposition of amyloid. It's the amyloid that damages the epidermis to see the color change. So, remember the epidermis is the most superficial layer, protective function, dermis supportive as well as immunological. So, if there's some problem in the epidermis, damage to the epidermis, the dermis reacts. Like what I said about the allergies, the topic there. Now these are cases that we all have admitted during my last few years. Oral ulcers, multiple ulcers. So few oral ulcers 5 days, okay, you think of herpes simplex. Herpes gingivostomatitis, intractable seizures. So, is it due to the herpes virus spreading to the brain? Herpes simplex encephalitis, or is it something else? This was normal. Additional information. The additional information is this child is the 6th in a family of 6 or 7. So think of this situation, there are 6 children running around, one is very sick, shouting, painful, ulcers in the mouth, can't take feeds. So the mother, youngest family of 7, she went to a nearby pharmacy, got this stuff. She asked for a pain relieving gel which contained little bit. Yeah. Now when you put this type of gel into the mouth cavity with ulcers, lidocaine gets absorbed, it causes neurotoxicity. So after we saw, we went to the internet. People are very happy to go to the internet. So that's quite described quite recently, 2016. So I always tell people, hear and see with wisdom. Most of us look with eyes, see with your heart. See with wisdom. Another common problem, inflammation in the skin. Now remember, inflammation is in the dermis because there are no blood vessels in the epidermis. So when you see an inflammatory disease, I think this picture is better than. The skin folds are involved. Erythematous, very symmetrical. No epidermal changes, which virtually exclude infantile psoriasis. So the diagnosis is streptococcal intertrial. Has to be treated with an oral antibiotic. Similar lesions can occur on the neck folds, armpits, and if you ask the mother, is there a foul smell from the skin, there is release. So streptococcal intertrial. If you don't treat, you will have problems. Glomerulonephritis, and our time rheumatic fever. Our era of rheumatic fever, malaria, cerebral malaria, typhoid. Some of them have come back. So that's streptococcal intertrial. Candidiasis would show you multiple satellite papules with scales. Will you treat it with the topical antibiotic? No. Topical antibiotic will act on the surface. You have to give either penicillin or cephalic cephalosporin. A straightforward one. Fever, rash. Now remember, in brown skin you don't see the erythema well, but in white skin you see the erythema very well. White skin, when you go to Europe and countries like that, the erythema is seen from a distance. Our skin, you have to maybe use a white light or natural light in dermatology in our setup. So the erythema is around the neck, a little bit of staging here. What do you call this tongue? It's called white strawberry tongue. So that's scarlet fever, another streptococcal infection. These lines that were visible on the folds are the Pastia's lines. Again, treat for 10 days with penicillin. Now this child we have been following up since birth. At birth, child had an ECG with a rash. The culture showed Staph aureus. Day 1. Peripheral blood, eosinophil. So if you have those two features in a neonate first day, think of hyper-IgE syndrome. And hyper-IgE syndrome is characterized by a phagocytic defect in the neutrophil. When the neutrophils can't phagocyte and destroy the organisms will live inside and the body will mount the granulomatous reaction. So these abscesses don't show the typical features of an abscess. That is, erythema, tenderness is not seen. So you see these bumps. Can you see them? So I had a task convincing the surgeons that they are abscesses, but they are not the classical. But the ultrasound will show the correction of pus. They are also prone to atopic dermatitis like rash. So hyper-IgE syndrome, as you can remember, there are different variations of it. STAT3 mutation and the other one. So the treatment is with IV antibiotic plus drainage. IND. Now this is known as pyomyositis. So it's diffusely infiltrated into the muscle. There are no sort of localized abscesses. So that's the same patient. This one. Some of them have multiple fractures, candidiasis. Now the message is this. Now skin infections are extremely common in children. When you see a child, always think whether the child is immunocompetent or immunocompromised. In order to verify the latter further, whether the child is immunocompromised, ask for a history of recurrent skin infections. Okay? Not only the skin, the other two organs that are in contact with the external environment. Respiratory system, GI tract. So they have recurrent respiratory infections, recurrent ear infections, recurrent diarrhea. Think of immunodeficiency. Now most of the time we tend to entertain a diagnosis of immunodeficiency because we don't have a diagnosis. Don't do that. Go by rational logical thought. Just because you don't have a diagnosis, don't create one. This is something that I learned from late Professor Dharma Sen. He would insist that we take the diagnosis history completely new in undiagnosed cases. The other feature is in immunodeficiency, think of HIV nowadays. After the COVID, I see a lot of patients with sexually transmitted diseases. In fact, we have diagnosed congenital syphilis, my time, and subsequent history, and we also have diagnosed with. And I am seeing a lot of adults with herpes. I think the numbers of spas have gone up dramatically. Now this child, maybe this rat, 8 years old child on prednisolone 5 TP from a different hospital, outstation, Western Province, outstation. Now what do you see? You see an advancing age, dry scaly rash. The classical tinea pedis is interdigital. This has gone beyond that. Not only that, it can go on into the nail also. The nails are discolored. So that means the child is little immunocompromised, what I call invasive tinea pedis. Now ITP, can you, is it because of prednisolone? Small dose, unlikely. So we look at the mother's tongue. Typical AIDS, oral hairy leukoplakia. Now, how do you explain ITP? Now, HIV appeared in the medical field when we were medical students. There were these young Americans who visited Haiti, returning back to New York with pneumonia. That was HIV, 1980s. We were medical students. Nobody knew what it was. After about 10 years, they came out with a virus called HTLV3. Human T lymphotrophic virus 3. To name it HIV, it took another 20 years. Even at that era, thrombocytopenia was a main feature of HIV. Isolated thrombocytopenia. So remember these patients with ITP, so-called ITP. Because the thing is, when we did the CD4 count in this child, it was 0. So fortunately, we were able to start on drug therapy for HIV and the child survived. Otherwise, child would have died of pneumonia. So remember, HIV in children is not HIV in adults. Children get common infections. You get herpes infection, herpes labialis doesn't clear. You treat that, it disappears, they come after a month with molluscum. You treat the molluscum, they come back after a month with scabies. Or, you treat the herpes simplex, it doesn't clear. You treat the tinea, it doesn't clear. And then often it comes from the mother. The mothers have features of SLE. High ESR, pancytopenia, positive ANA. It's mine because there was a patient who was put on prednisolone for SLE. Because ANA was positive. They have dry skin. Look at the tongue, side of it. The other feature of HIV in children is this a mixture of staph infection, papular area, scarring, pruritic papular eruption of HIV. These are all taken from my clinic when I was here at LRH. The pruritic papular eruption is not only suggestive of HIV, it's a good predictor of a low CD4 count. So that means you have to act very fast. Don't expect the adult version of Kaposi sarcoma and all that stuff in children. At least initially. Now thrombocytopenia, you know, either reduce production or increase destruction. But a lot of new things have emerged. The role of megakaryocyte, and the megakaryocytes monitor the plasma cells. The megakaryocytes are the ones that give rise to the platelet, but megakaryocytes are monitored by the plasma cells. So what these viruses do, including dengue, chikungunya, HIV, is to act on the plasma cell to prevent the neutralizing antibodies forming. And this is a novel mechanism that is being implemented in the thrombocytopenia of lot of infections. Same with HIV. So what I did was to put this is what I said here, 83 we were in the final year. Now coming back to simple dermatology, lip pigmentation, parents bring the children because they are very concerned. And when you see pigmentation, remember biologically we pigment brown skin. Naturally we are prone to pigmentations. Now don't jump and think that this is Addison's. If it is Addison's, the pigmentation is uniform here. There is a break between the two sides. So this is a child pressurized by the mother for the scholarship, and the child is doing this all the time. Giving the tongue. Friction induced pigmentation. Same with hair. Namai lehma karnawa, gullanawa, amaranawa, karkonawa, amagalonawa. Very common. Day before yesterday, a lady doctor turned up with alopecia. So she had been to so many people. So I asked, if history, there's a medical officer, you take a little longer history, no, history, I asked her, have you got any problems in the armpits? So she looked at the husband and said, so why did you ask that question? I said, have you got it down on? No, I get abscess in the armpits. Right? Armpits also have hair, common sense. Then I asked, how many children have you got? He said, 3. I said, all 3 are daughters, no? He said, how did you serve you? So I said, it's not yet over. How many abortions have you had? Then she again looked at the husband. So she said 3. So I said, they are male fetuses that had been aborted, where she is a carrier for the hypohidrotic ectodermal dysplasia. Can you see the connection? So when you have that gene, the hairs don't function normally. They fall off and you get hidradenitis in the armpits. Okay? This is what people need to focus on. You have good knowledge and how to use that knowledge practically. Then අපි කොච්චර හොඳට දැනගෙන හිටියත් driving rules පුළුවන් ඒ විදිහට අපේ පාර යන්න. Then it's like that. Yeah, these are family members. They like to cuddle up every day. Unfortunately, one was caught by my cat recently. So, they 3 brothers. Sometimes still they try to drink milk from the mother. Now only 2 are there. This child came with pigmentation. Went to family, rich people. So women said that Dr. make a cream and be careful of this. You can get a cream and get away with it. But one day, if you have missed something, you get only the blame now. People will not remember how long you took to how brilliant your diagnosis or this thing. They will remember our shortcomings. Our shortcomings and how much they suffered in the hospital. This is the mother. So I said, Mathiana is the day. Then the father said, I have a picture. He produced it. So this is lupus paniculitis. You see lupus paniculitis is SLE. You don't have to have criteria. Lupus paniculitis is like the CD4 count in HIV. So she is even now on treatment. So be careful of seeing a condition at the end point. Always ask. Lot of people, fortunately, take a picture now. Very good. Because then we know the disease. Like අපිට ඇඟිල්ල උණ අත්ත කියලා කියනවා නේද? සුමාන 10ක පිස්සෙල්ල උණ ගත්තා. අපිට මතකද සුමාන 10ක පිස්සෙල්ල මොනවද කරේ කියලා? Because the patient. So have they monitored? කට්ටෙන් බැලුවද නේද? හරි අමාරුයි ෆිසිකල් ආර්ටිස් and easy thing. So swelling disappeared, but the pigmentation persisted. Now it looks like a sort of a slap on the face. Now don't jump and say that I can use and no. Don't have insult to it. That's a warning. That's why I put very close this thing. Phytophotodermatitis is this plant liquid that causes photosensitivity. Lime leaves and lime juice act as solvents. Linear light containers is different, so that's lupus. These are all cases that we have seen over the years. Child with fever, undiagnosed fever, investigated in Mediclo, the peculiar rash, the erythema type of lesions. But look at this lesion. That's a discoid lupus lesion. And here you see the heliotrope. So you put two together. Dermatomyositis, SLE, overlap. So this is the art of dermatology. You see the disease, you interpret and put it into one. Why not? It's always a luxury to get an acute clinical diagnosis in clinical practice. So we get for the juniors, heliotrope means sun pointing. It occurs on the upper eyelid, not on the lower eyelid. Helio is sun, trope is pointing. Heliotrope. That can be unilateral. Recently, I had a lady, rich person, came and said, "Doctor, I am allergic to the shampoo. Her face is swollen." So I said, "Okay, what is the shampoo and all that?" We'll do a simple test, and I ordered a CPK, very high. Acute dermatomyositis can be very misleading. The initial edematous phase can make you think of even bee stings. The face is so much swollen. You have to be careful not to miss that type of thing. Other feature of dermatomyositis in children is the scalp pruritus. Intractable scalp pruritus. These are unusual cases that I have seen over the years. I need to mention because one day you all will come across this. So the overlap syndrome. Now I showed the picture of my consultant, UK, Professor Kandi. When I was a trainee in 92, his teacher used to come, Professor Rowell. He had described this as a Rowell syndrome. If you go to literature, as a subset of SLE. based on these lesions. Erythema multiforme type of SL, Rowell syndrome. So once you see, go back to the internet and unfortunately I'm not good with my internet. Of course my children are experts on the field. I used to get my SR. He's very happy to hide. So, that's good. Now this child. Yeah. Now sometimes in clinical medicine we are happy to see a case that we have seen before, no comment. Then straightforward treatment. Now this type of thing turns up, you don't know where it is. Now this child was referred by the eye surgeon. Day after tomorrow they are planning a reconstructive surgery. Now that's a bit annoying because it may be dangerous, because if it is something dangerous, I think, I don't know whether I have included that familial dysautonomia patient who used to eat the mouth, and they constructed the lip after 7 hours of surgery. The following day, the child has eaten that also, including the sutures. So the actual treatment would have been to extract the teeth when the child can't bite. So this is a skin condition known as pyoderma gangrenosum. That's after a week of prednisolone. No surgery was in. Years later the child developed this type of lesion. In pyoderma gangrenosum the ulcer is acute, the base is very wet, and you see this bluish necrotic edge, and it heals with tissue paper scarring. You see that? It's like seeing an elephant. Today you saw the trunk, tomorrow you saw the ear, then you saw the foot. Even in Colombo you can grow cabbage. Yes. I'm really enjoying my retire. Thank God I'm not here. මේ mushrooms කොච්චර ඉක්මනට වෙනවද කියලා. We didn't make the beers, no? And how many these tiny insects live on those? Ayyo, Vietnamian he's an electrician now. He's about 10 years ago, 15 years ago. He had I have included this to highlight on the misdiagnosis, that the tragedies of monkey whale, Chekhov kid whale. So he became very sick, he was dying. He had applied for a driving license and they have rejected. They have said, with modern these gadgets, you don't need many hands and many fingers, no, coupling one. But they have not amended the law. So he developed multiple abscesses, which were red. The diagnosis was this scar here in the armpit, which was due to the BCG adenitis, indicating that he is prone for mycobacterial infection. So Mendelian predisposition for mycobacterial infection. Some people by nature are prone to mycobacterial infection. You give BCG, live attenuated bovis, you get abscess. Later they acquire atypical mycobacteria and it disseminates. You give steroids and methotrexate, disseminates further, resulting in necrotizing vasculitis. I have seen 4 cases. One ended up like this, she was in a different ward. Now, out of interest, there is a leading scientist, Sri Lankan, working in leprosy, US. He was here for the season and he said the leprosy bacillus do 2 things. One is it converts Schwann cell into a stem cell to survive. Wonderful stuff, because neurological treatment can be used by that technique. Now he says Mycobacterium leprae can regenerate the liver. So no worries, even if you remove the liver after a while, you should be able to put one. So that's that thing. Now when you see this picture, you know the baby is sick with the nasal prongs and all that, fever, this rash. This is how disseminated Pseudomonas infection starts. Mild erythematous spots which rapidly spread. You might see a little bit of a spike like that. And very rapidly these lesions progress. If you see that type of lesions, it's an emergence to start on anti-pseudomonal, penicillin and cephalosporin. Yeah. They progress very rapidly, and if you have a similar lesion on the ear will be destroyed. Malignant otitis externa. So that's known as ecthyma gangrenous. These are little advanced cases. These are very unfortunate children with various neutrophilic diseases. The neutrophils, nobody knows why they attack the skin. It's being worked out. They attack the dermis, they attack the fat, they attack the joints, they attack the communities, they attack the joints. And we have this. Yes, anybody from the audience, the fever pattern? Now, our internship, late Professor Dharmasena used to shake the BHT and look at the temperature chart first. That's called periodic fever. Yeah. Now, two pictures to show very sick type. Now, sometimes you see people daytime covering this. That's photophobia. Think of a photosensitive disorder. That gives you a clue to the correct path, you know. Be very fast in this. So she has a little bit of central nervous system, pigmentation, and a scaly rash on the field. But she has been in hospital for a psychiatric disorder for months. Doesn't take meals. So this is what is pellagra. All you have to give is to give niacin. The product that contains highest amount niacin is polybiol syrup. My mother lived up to 90 years. When she was 80, I noticed a change in her behavior. She had become very scared. Roll lock karna, leaf lock karna, that was unusual. So I started on polybiol. Within a week she came back to me. So this can be so subtle, the niacin deficiency. If you have noticed some behavioral change in your parent, elderly, think of pellagra. Don't expect to see the classical Cassell's necklace and photosensitive rash that you see in adults who are running around the world. Inward patients, pellagra will be causing this type of frictional dermatitis with pigmentation. The other features like diarrhea, maybe there, may not be there. Yes, so the current thing about nature photography is not taking a rare animal or something like that. You create an image using Mother Nature. So is a ordinary alakole. Because they have that thing, alakole is heaven and luck Latina. So that's. Now another problem that we encounter in clinical medicine is people who come with number of organ involvement. So you have fever, joint swollen, liver disease, cancer, pneumonitis, heart disease. So you have to work out the mechanisms by which different organs are involved in a disease process. මේවා මම හිතන්නේ ටීච් කරන්නේ නැහැ නේද? medical school අපි නම් ඉගෙන ගත්තේ නැහැ මේකක්. Which I have worked out over the years to survive. We have to survive on a daily basis now in modern medicine නේද? Ward එකට ගියාම මගේ thank God I don't have that problem. So it can be inherited or acquired. Basic classification. Inherited multiple organs from severe ectodermal dysplasia again, and all that. Abortions and all that. Okay. Let me give an example. Now these are cases that have been admitted, seen by medical officers elsewhere, seen by MOPD, seen by interns, seen by SRs, registrars, neither. Very sick, swollen and all that. Lotions, scaly rash, So that's cystic fibrosis. Can't say, couldn't say, right? Yeah, now cystic fibrosis, we think it's always the lung comment there. Now, how do you put acquired causes? Toxins, drugs, autoimmune, cytokine mediated, infections, chronic, remember melioidosis, especially central nervous system. Some medical officers died at NHS diagnosed. So if you work through this lot, and there may be few others that I have missed, you should be able to get at the diagnosis very accurate. Then base your investigations according to and start on treatment. This is a boy admitted from the OPD, headache, fever. Okay. There was a vesicle here. So you saw the vesicle swelling, soft. That's good, that's a good guess. But what about this lesion? Linear infiltrated lesion. You don't get that in zoster. So this is an arteritis. Acute idiopathic facial arteritis, I would call this. I have seen about 10 cases in my 20 years here. A devastating condition. And after treatment, anybody from the audience? What complication has arisen? Yes, anybody?
Ptosis.
Last one?
Ptosis.
Yeah, ptosis. Ptosis is part of it. A Horner syndrome. I told you arthritis. Read the reason. Sympathetic innervation of the head and neck is different from the rest of the body. The sympathetic fibers of the head and neck follow arteries. You have an arthritis, the sympathetic fibers are damaged as a collateral effect. That's why the Horners. I hope you don't see this ended here. But terrified. During the pediatrician was here some time ago, that is not.
Doctor also.
GN Lucas. GN Lucas.
No. Yeah, 10. He had a child. Died the most miserable way. We managed him for 3 months. He had a tumor in his stomach. Yeah. So that entity you need to hit with IV dexamethasone, maximum dosage, along with methotrexate and Dapsone. This combination, subsequent patients survive with disabilities. One got a myocardial infarction, one got a renal infarct. I don't know what's triggering off that arthritis. That's how they come. It's always boys, headache, fever, something on the face, unilateral. You give IV acyclo, it goes to the other side. This one came in the private sector. Now again from the back row, it's tiring work, what to do? Anything common to headache, fever, vision, tinnitus? Any particular cell that you can work out from this? The melanocyte. The melanocyte is found in the eye. The melanocyte is found in the inner ear and the leptomeninges. So acute autoimmune attack one. IV urgent. I have seen 3 cases in my career. You have to give IV dexamethasone to save the eyes. Because some of the eye melanocytes, when they are destroyed, the patient goes blind. You can't do anything subsequent. And that had been described well in Corona. Of course, there's a mania sweeping South Asia about සුදු වෙන්න ඕනි, ලස්සන වෙන්න ඕනි, හැමදාම එහෙම ඉන්නත් ඕනි. මොකද වෙන්නේ නැහැ. අයියෝ. So menace, especially young girls, their faces are so fair. Look at their bodies, acne on the back, striae. Virtually, they put clobidazole, dermoid. When you apply dermoid on the skin, it becomes so beautiful, like this girl. So this mother treatment with this child was referred by now the Mahitan. Teachers of pushing, see they can't find the etiology. Amma illa kina mehema. Doctor ta kiyanne මේ පරම්පරා තුනකම කාන්තාව හරිම ලස්සනයි. ඒක කිව්වම අපි දන්නවා මොකද වෙන්නේ. කොහොමද සිල්රයි dexamethasone කොහොමද ළමයන්? සිදුවේ. They want that to know what's the role but ලස්සනයි වැඩේ කියලා. Can you see the stripe in the mother? And stripe steroid induced is pink. This is what will happen. Now, be careful of the products that are available in the market, especially fairness. I'm sure you encounter this. It's a real menace. Some contain mercury. Mercury permanently inhibits the tyrosinase. Glutathione diverts the melanin synthesis to pheomelanin. Pheomelanin කියන්නේ අර අපේ ඉස්සර තිබිච්ච melanin එක. It's easily destroyed. Because pheomelanin හැදෙනවා ඒක destroy වෙනවා, you become fair. Glutathione was originally used as an antioxidant in chemotherapy. අපි medical students කාලේ. හැබැයි cancer patients මැරෙනවා සුදු වෙලා. So they stopped using. It's like that, the story of that. ඒක නවත්තලා මේක fairness එක. අක්ෂර දෙකක් ගන්නවා ගන්න. There are braces which give the glutathione IV index ගන්න. ඉතින් සුමානේ දෙකක් හොඳට සිදුවට ඉන්නවා ආයි ගන්න. බංකොලොත් දෙකක් ගන්නවා. Some are very unfortunate children and may not have a now you might think this is psoriasis. Everything that flakes is not psoriasis. Psoriatic scale is powdery, silvery, and on the scalp you can feel it better than seeing the scale. Psoriatic scalp එක ඇල්ලුවාම අහුවෙනවා ගෙඩි ගෙඩි. And are there any dermatology trainees? No. Exam එකේදී මම බලාපොරොත්තු වෙන්නේ මෙහෙම අල්ලන්න. Some touch like this. That's not professional. Use both hands. Use both hands. ඉස්සර අපේ Prof ධර්මසේනක මොන කරාම වැරදිට ඉදින් ගාලා එකක් දෙනවා. Oh. And he always preferred boys to come to him. Myself and Kulrat were retired from Canada. He survived without a single So this is candidiasis, chronic mucocutaneous candidiasis. I'm trying my best to correct this nephritis that is there in the lacrimal glands. Now, how do they change color? They have chromoforms. එක පැත්තක් රතුයි, මේ පැත්ත කොළයි, මේ පැත්ත කහයි, කොටහරොයි. The color doesn't, the pigment is not synthesized immediately. They change the shape, direction. පොළ පැත්ත මෙහාට දාන්න. මේ කලර් එක්ස්පෙරිමන්ට් කරන්නේ ඒකයි pigment. අපේ pigment ඉතින් අපි තියාගෙන ඉන්නවා. Yeah, you are familiar with the post-COVID syndromes, no? Kawasaki like AC. COVID those. So temperature charts. Always look at it because it gives you a clue. This is called a saddleback. Do you still see people this in the coming?
This thing is not.
Kawasaki, yeah? Are there Kawasaki?
Kawasaki, yes.
I miss that type of acute medicine, you know, I really enjoy it.
We see again, there are.
So Kawasaki shock. Now when you see a patient with Kawasaki shock, I always diagnosed long time ago. I used to live with IVIG dexamethasone. The argument is this: these patients have hypoalbuminemia. So when you don't have albumin within the blood vessels, it's like a deflated tire. It's something that I learned from late Professor Dermatologist. When it comes to blood vessels, for perfusion of organs, the blood vessels should be filled with plasma and red cells. If they are depleted, so to get fluid, keep the fluid inside, use few doses of dexamethasone. That improves the perfusion very well. And the dramatic effect may vanish. Same unfortunately, OMF people referred us after this happened, not before. Familial dysautonomia is children who are born with hereditary lack of pain. Don't very Now about vascular birthmarks, I should touch on this. It's a very common occurrence. There are two basic types. Vascular tumors, hemangioma is the commonest vascular tumor of infancy. On the other side, you have vascular malformations. Malformations are present at birth, grow proportionately to the growth of the child, persisting to adulthood. Hemangiomas on the other side are not present at birth, but there can be a precursor lesion, from which the lesion grows. The problem is we can't tell to which size it will grow. So if it is a cosmetic sensitive area like the face, the breasts of a girl, right? You have to be very, very careful, because I have some girls who are 10, 20 years without a breast. The hemangioma had grown, destroying the breast tissue. Now the hemangioma has involuted, there is no breast. So never tell the parent that this will resolve. You can't say that. Better to get an opinion of somebody, because these are very treatable with either topical timolol or propanol. Very well treatable. There was a very unfortunate incident about 5 years ago. Doctor working at NHS, the child had a liver hemangioma which was not treated. And then they called me to the ICU one day. The child was brain dead, because when the hemangioma rupture, the liver hemangioma, the CVS just deflates. There was no blood in the heart. So what to do? And somebody recently told that she is psychiatric now, the mother. So hemangiomas, for heaven's sake, if you have any doubts, really is here. Then මෙහෙම පටන් ගත්තට අපිට කියන්න බෑ මේක කොච්චර size එකකද ඉන්නේ. That's a problem. They grow during the proliferating phase, which lasts for about 4 months. 4 months. A period එකේ propanol දුන්න නම් resolves. So they can be classified superficial, deep, growth pattern. I have described how they grow. Some have a rapid proliferative phase. It was a static. Some places like the preauricular region, the growth phase lasts few years. So they call it the propanol. Propanol acts during the proliferative phase, not before or afterwards. So I am not going to go into details. Angiogenesis is formation of new blood vessels. Okay? New vessels are formed. You require angiogenetic factors. Now, this baby had only this lesion. Within few weeks, see how fast it had grown. So there you hit it with propanol. Very safe drug. 3 milligram per kg per day. We as a precaution do a cardiac and assessment. But my colleagues in UK and Germany, they straight away give it as an outpatient. They don't wait for me. They got a powder, they can get it there. So something that I have recognized is upper body hemangiomas are different from lower body. Their associations are different. Upper body, the famous one is the Facer syndrome and necrotic. Posterior fossa hemangioma, arterial, prostration, iatonitis. Lower body, renal, sacral, number of malformations. Hemangiomas can be 1 or hemangiomas can be 100 on the skin. And the other 2 organs that are likely to involve is the liver and the airway. Airway is from the pharynx to the trachea, not the other. So if you have a hemangioma on the beard region, be careful not to miss a airway hemangioma. So That's a typical faces syndrome with these sternal abnormalities. Supraumbilical graph image. The umbilicus again පල්ලෙහාට යන්නේ. So the upper body behaves differently. I can't understand. No. How hemangioma, which is probably originated from the placental stem cells, survive because of the hypoxia in the skin. They grow. But how do you explain the association with other malformations, brain defects? Yeah, this is after treatment with propranolol. See the effect. අපි මේ වුණ කරේ ප්‍රසන්ටේෂන් එක හදනකොට මේ පින්තූර දාගෙන ඉන්නකොට අම්මා කෙනෙක් කියලා කිව්වා බබාගේ ඉස්සර ගත්ත පින්තූරයක් ඔය තියෙන මේ ඉන්නේ බබා. So that's another picture. Residual layer තියෙනවාද? Telangiectasia. See the eyebrow. This is what I am saying. They leave a mark. So catch them early, treat them early. If you have a small hemangioma on the back which is not visible, either leave it alone, or if they make a big fuss, timolol eye drops ටිකක් ගන්න කියලා. Timolol eye drop එක. ඊට තද කරගෙන ඉන්න because the epidermis is centered, you have to drive it in. ඊට තද කරන්න. I go a step further, I use metronidazole. Remember, in our body, this reactive oxygen species is very damaging. One thing that neutralizes reactive oxygen species is metronidazole. So much so I treat my vitiligo patients with topical metronidazole. Never stay like a prisoner in medicine. Explore කරලා බලන්න පොඩ්ඩක් beyond යන්න reasonably. ඕනේ වනේ පොඩ්ඩක් එහාට ගිහිල්ලා on a rational basis. That always works. Abandon These are examples of lower body hemangiomas. Ulcerate nama, what do you do? Ulceration is very painful. Likely places for ulceration are the eyelids, ear, neck, perineum. ඔය තැන්වල තිබුණොත් give propranolol early. Don't wait till it ulcerates. Once ulcerated, especially on the lip, the child can't suck, take milk, no problem. So treat early, maybe a hemangioma. Here's another child we treated. Now these telangiectasia can be treated with lasers. Unfortunately, we don't have a vascular laser, but I have a contact in South India, very young chap, very good person. After the economic crisis, one Dr. Selva, he had sent a message. He calls me, sir, for I don't know for what reason. Sir, I will give your patients 50% reduction. See how good they are. Lankavedan thaviya kare very good. Here some of them after treatment. So these are the indications for propranolol therapy. You give it for the proliferative period. I have used it. We use propranolol when we were interns as the major antihypertensive at ERA. So we are quite familiar. And I remember one particular incident during the internship. They call it propranolol, salbutamol, pink colored, identical tablet. One day for an asthmatic patient, they gave propranolol. So he was rushed. There was no air entry. We intubated with a tube dala. Very good at මේවා ටෙටනස් ඒවා අපි ඉන්ටිබේට් කරනවානේ මහපාරේ ඉඳලා කොරිඩෝර්ස් වල දානවා ටෙටනස් පේෂන්ට්ස් වල ටියුබ්ස් ඒ කාලේ so still I'm very good at putting a tube into the lung airway still nothing right මෙහෙම වෙනකන් ඉන්න එපා මේ. බලන්නකො. මොකද කරන්නේ කියලා දැන් මේ සර්ජරි කරන්නත් බැහැ. කරත් හැපෙන්නෙත් නෑ. Remember, eye is an organ of reflex. Light තියෙන්නම ඕනේ නැහැ. For development. There's no light, no eye. මේ concentrate වෙලා මේ බලන්න තියෙනවා. So send them early. The other tumors, congenital, some hemangiomas are present at birth. They are known as congenital hemangioma. The growth phase has occurred in utero. Okay, vella thamai pilidana. The others, growth phase occur during the infant period. Other conditions, number of malformations, growth related Proteus syndrome, other tumors which can consume platelet. Corona period, this child came with a platelet count of 1,000. So you give dexamethasone 90, bring the platelet to a stable level and then use methotrexate. But lot of people use vincristine. If you give vincristine, you create a neutropenia also. Not so with methotrexate. Remember tumors in childhood. Anything that is red lump is not a hemangioma. This is a neuroblastoma. What you see here is a telangiectasia. The red color comes because of the dilated blood vessels. Melanoma high tumors. Hemangiomas empty. Adakarana blood vessels it empties. Don't miss it. So these are the complications of liver hemangiomas. It's something that I learned, hyperthyroidism. I'm glad that I came to LRH. I learned so much of pediatrics. Deiodinase. Consumptive hyperthyroidism. So you create that shadow to complete the image. You send this to BBC, they send you a certificate. I'm sure you all are under, the drug reactions are coming along. Steven Johnson. Lucky. Very fine. Complex problems. Now, you are familiar with chickenpox virus, no? Varicella zoster. Then you get later herpes zoster. Herpes zoster can be unidermatomal. Herpes zoster can be multidermatomal, different places, no problem. Multidermatomal, 3 or 4 adjoining ones, HIV. Then you have a very rare entity called, recently I saw a consultant, severe perineal pain, unilateral, no vesicles, put him on IV acyclovir, 1 week, he is completely cured. That's called zoster sine herpes. You don't see the vesicles, that phase is aborted. But it responds to IV acyclovir very well. I'm so glad that I put him on. Like he couldn't sit. Can you imagine the zoster pain can be terrifying? Like මට කියන්න මේ patient ගේ maxillary zoster තියෙන්නේ. ඇයි අපා eyelid එක swelling වෙලා තියෙන්නේ කියලා? Oh, the maxillary division is here now. Yes? No, there's involvement of the nasociliary branch. Okay? Okay? Now I had a visiting German dermatologist, a young girl. She spotted it. All the others being spotted. She said there's nasociliary branch in body. නෑ හොඳයි ඉතින් කවුරු හරි people are differ in their ability, no? Dermatomyositis induced skin ulceration. Male SLE, remember? This is called chilblain lupus. Chilblain lupus occurs in Eurasia, Victoria, Asia, or Europe, Russia, in cold countries. SLE on the feet. When you have cell, I'm sure you must be seeing it regularly. Which I did for a few hours actually after admission because the lung was so badly damaged. They have been treating a seborrheic dermatitis somewhere in Ampara or Kalmu. Yes, this pigmentation thing I would suggest you use your hand as a tool to compare. Apart from pigmentation, කිව්වටම ගන්න එපා. Then lot of parents come and say, "බබාගේ මූණ සුදු වෙනවා." You know that's fear of vitiligo. පෙරේදා බබේ කෙනෙක්න මේ බලන්න සර් මේ කන කො බලන්න කන. ඒ හතර දිනක් කොට වෙලා කන බලනවා. Nothing. So then I tell the mothers, even there was a keloid behind the mother's ear. That was the diagnosis. Fear, why? Make a project karna lamaya. This we saw Dharmasena, the Professor Dharmasena used to tell about this pseudomyocardial infarction. Propunne කියන කාටද heart attack හැදුනේ ගෙදර ආසර් විශ්මානේ අපේ අයියට දුනා ඔයාට දැන් හිතේ හැදලා තියෙන ටිකට් කපලා discharge we had 40 beds and 200 patients. Can you imagine this? So, Fanconi anemia, pigmentation. GKIDK syndrome, dannada? God knows, I don't know syndrome. ICWT is I know, won't tell you syndrome. That happens in ND exam. Yeah, touch on acne because some of you may be interested in when acne is a problem that you encounter in the teenage years. The acne patient can come, they have many expectations. It's not just clearing the acne. Acne clear karla ඕනේ. Scars වලට මොනවා හරි කරලා ඕනේ. අර oily skin එකට මොනවා හරි කරලා ඕනේ. ඒ කියන්නේ නැහැ මිනිස්සු. Then they want little bit of clear face. Huh? That's driven by the media. Actually. So we have to address කරා. Remember, acne is a problem in the pilosebaceous unit. Then we block it again here. Can you see the block here? Whatever you apply doesn't reach the gland. Then most of the acne treatments are applied on the surface now. Take retinoic acid, benzoyl peroxide, antibiotics එනවා. ඒවා ගෑවට වැඩක් නැහැ. Doesn't reach the target. So what I use is glycolic acid. Use glycolic acid, open this, the other one follows. එනකොට hina වෙවි එන්නේ සර් දැන් හොඳයි කියන්නේ. And glycolic acid is a super product. It's from sugarcane. It's very skin friendly, acid pH, and also contact skin color. If you can see my face, it's quite good. The mace cast sadala denna oni. I use a special. I don't use the laser. I don't use peels. Peels are in normal skin remove. You know what basis is there? I use targeted heat therapy. Plastic adala denna, which I have worked on for 30 years. So that's a word dermatologist. Among the girls also there are dermatologists. Yeah, so that's a giant enanthem of infectious mononucleosis. Usually the enanthem is tiny dots, rubella or infectious mononucleosis. These are large lesions, effectively. Giant enanthem of that's seen in 10% of infectious mononucleosis patients. So this is the entity known as mycoplasma-induced mucositis and rash. Mycoplasma infection is not a cause for erythema multiforme. This is what you see. Yeah, can you see the pneumonia? Sometimes there is only one lesion. That's enough for us to see. And in mycoplasma, I think Andrea and Deepal will agree. The radiological changes are disproportionate to the clinical findings. They are massive here, but they are quite alright. Tuberculosis. Yeah. So when you have an infection, the organism can directly damage cells. Now you have hepatitis B virus, hepatocytes are damaged. Sometimes the immune complexes damage. That is, the antigen comes from the organism, antibody from you, they deposit and cause a vasculitis. In tuberculosis, this is known as a peritoneal keratoconjunctivitis. Make a Miss Karanang internship, Dharmasena will hang you to the nearest light cover. This is no Samavan. Do you see mediadosis? Mediadosis? Yes. Menace. When you see a couple of cases in the private sector. Unnagala, Katara, where later? In mediadosis, the erythema multiforme is actually pigmented. You don't see typical erythema multiforme of primary tuberculosis or sarcoidosis. This is what you see. Large number of lesions, black. And if you are lucky, you see oral abscess, skin abscess, skin ulcers, and low grade fever, sometimes no fever. Now, medical officer who died of NHSL, the wife turned up with the reports and some photograph. This is the congenital syphilis. This is that we diagnosed recently. I think, do you want me to go few slides or are you dead tired? Now this is pemphigus in the baby, neonate. So the antibody has crossed. Antibody has caused the damage. The antibody is not being produced. So just treat this as a burn. Don't give steroids to the baby. There is no rationale. Okay, just use silver sulfadizine cream. Treat the mother with steroids. Where the antibody has crossed and caused the damage. So this is one criteria for you to diagnose an autoimmune disease. That is, if the causative agent has caused the disease in the recipient, which occurs only in pregnancy. That's number one criteria for the diagnosis of autoimmune disease. We resort on demonstration of autoantibodies. Autoantibodies kalla pikina, this is an autoimmune disease kela. It's not a very good criteria. This is the best, a clinically based one. If the putative immune defect is transferred, it results in clinical disease. The offending IgG antibody crossed the placenta and gave the disease to the baby. Clear? Just demonstrating autoantibody is a weak criteria. The weakest criteria is response to immunosuppressive therapy. Make a best criteria. I repeat it. If the putative immune defect is transferred, it results in clinical disease. Mother has pemphigus, the baby got the IgG antibody transplacentally and got the disease. Same with neonatal lupus. Hand, foot, mouth, all that. I won't go to leprosy because it's too tiring for you all. It's not fair. But I have not included atopic dermatitis, molluscum eva. You will know what to do. But my message, I wanted to convey a message about learning, which I do even today. Even today I read for half an hour at 4:30. I sleep early, wake up early, read for half an hour. So, especially this crisis, we have to do our part. Whoever had failed in this country, can we use that to say we also must fail here? When the country falls, people should stand up, not criticize and blame and fight. I don't mind answering. There's also a widespread epidemic of tinea infection, both in adults and children. Most of them are drug resistant because of the use of prometheazole. During the corona lockdown, people with tinea didn't have any choice but to apply what is available in the home. So they started applying benzoate and all that. Then drug resistant. So what I do is to use two systemic agents targeting the two different places of ergosterol synthesis. I use griseofulvin and itraconazole. If you use one drug, the fungus becomes resistant to that drug. There's no other way.
So hand, foot, mouth disease are unusual presentation. Like we see sometimes burn radiation, hand, foot, mouth.
Yes.
Unusual.
Especially the larger blisters on the feet are actually much flatter. They complain of difficulty in walking. And the other thing, Deepa, it's not the typical hand, foot, mouth that you see. You classically see knee, buttock, elbow. Important features are one, fever. Ask for a history of diarrhea. Some degree of diarrhea in most of the patients, and contacting the school or the preschool, nursery. But if you see hand, foot, mouth, keep a zinc supplement, otherwise the nails fall off. Syncopene nail syrup.
Vitamin D also. Some adding vitamin D also.
Yes. Vitamin D deficiency is other menace because children are now computer, studies, no sun exposure. No sun exposure.